Today, we are talking about idiopathic intracranial hypertension. This is a condition where intracranial pressure rises without a clear underlying cause.
No tumor, no infection, no mass lesion. It's sometimes called pseudotumor cerebri because the symptoms can mimic those of a brain tumor.
Idiopathic intracranial hypertension is most commonly seen in young, overweight women of childbearing age, but it can affect anyone. Key risk factors include obesity, rapid weight gain, hormonal changes, and certain medications like tetracyclines or steroid withdrawal, and possibly genetic predispositions.
Increasingly, researchers are also looking at venous sinus stenosis and disturbances at the glia-neurovascular interface as contributors.
The incidence of IIH is rising worldwide, largely tracking the obesity epidemic. In the United States, about 1.15 per 100,000 people are affected each year, with women far more commonly affected than men.
Social and racial disparities are also present, with higher rates among those in low-income groups. The hallmark symptoms include severe daily headaches and pulsatile tinnitus. That's a whooshing sound in the ear. We also get transient visual obscurations and double vision.
The key sign to look for is papilloedema or swelling of the optic disc. If untreated, this can cause permanent vision loss. Now, diagnosis. This is made using the modified Dandy criteria, which is symptoms of raised intracranial pressure, papilloedema, and normal brain imaging, and an elevated opening pressure on lumbar puncture, typically above 250 millimeters of CSF. It's
essential to rule out secondary causes, such as venous sinus thrombosis or brain tumors.
Visual field testing is also crucial for baseline and follow-up. Management starts with lifestyle interventions, and weight loss of just 5 to 10% can dramatically improve symptoms. The first-line drug is acetazolamide, which is a carbonic anhydrase inhibitor that reduces CSF production. Topiramate is another option, especially in patients with migraine features, and diuretics like furosemide may also help.
For patients with visual-threatening IIH disease or refractory symptoms, surgical interventions are considered. These include optic nerve sheath fenestration to relieve papilloedema, cerebrospinal fluid diversion via shunt procedures, and more recently, venous sinus stenting in carefully selected cases.
In severely obese patients, bariatric surgery can improve long-term outcomes. Challenges remain. Not every patient has papilloedema, so atypical cases can often be missed. There is debate about what counts as abnormal opening pressure, and while many interventions are effective, high-quality randomized trials are limited. The prognosis is generally good,
with early recognition and treatment, but delays can lead to permanent visual impairment. Headache, burden, and visual changes can significantly affect quality of life. So,
in summary, idiopathic intracranial hypertension is a complex but treatable condition. Recognizing the risk factors, ensuring timely diagnosis, and using a structured management approach are key to preserving vision and improving quality of life. With obesity on the rise globally, awareness of idiopathic intracranial hypertension is more important than ever. Thank you for listening and have a blessed day.